This evening, I'm hoping to cover several topics of interest to this audience. We'll go over a definition of osteoporosis. We'll discuss who should be thinking about their bone health and tested and screened for it. We'll discuss ways, both lifestyle and medication, that we can use to improve our bone strength and prevent fractures. And then we'll talk about, finally, the medical options for treatment of osteoporosis and some common concerns about safety. So let me start with the take-home messages that I hope you'll carry away from this evening's talk. The first is that fractures due to osteoporosis are indeed serious, but many are preventable. Fracture risk depends on many factors, which we'll review. Lifestyle changes can slow, but usually not reverse bone loss. And when used properly, osteoporosis medications are very safe and very effective. All right, so to get started, let's discuss the definition of osteoporosis. The word literally means porous bone, and it refers to a decrease in bone mass that leads to increased fragility and an increased risk or likelihood of fracture. So osteoporosis is a very common disease. Half of all women and at least a quarter of all men will experience a fracture due to osteoporosis sometime in their lifetime. And just to put this in perspective with other common chronic disorders, within the US, there are approximately 34 million adults who have low bone mass. This is very similar in numbers to those who have high blood pressure, and just somewhat lower than those who have high cholesterol. What's often underappreciated is how devastating osteoporosis fractures can be. So each year in the US, there are approximately 300,000 hip fractures, similar to the number of cases of newly diagnosed invasive breast cancer, maybe half of the number of heart attacks or myocardial infarctions that happen every year. The most sort of shocking thing about hip fractures that occur in the US is that the mortality within 1 year is very high. Almost 1 in 4 individuals will die within a year of having a hip fracture, not necessarily because of the fracture itself, but because of some of the complications that happen afterwards. And you can see that this 1-year mortality is much higher than you would expect after an MI, and even higher than that of someone diagnosed with cancer. As another way to think about it, the risk for women of being diagnosed with breast cancer is 1 in 8 or 12% over a lifetime, and compare that to a 50% chance of experience of fracture due to osteoporosis. For men, the risk is more similar to a lifetime risk of being diagnosed with prostate cancer, as having a fracture, roughly about 20%. What kinds of fractures can be attributed to osteoporosis? Among the most common are spine or vertebral fractures, about a quarter of them. It's also very common for women who fall, maybe slipping on the ice or the snow, falling on an extended wrist, can experience wrist fractures, about 19%. We've mentioned the hip fractures that are so deadly, those are about 14%. And the remaining osteoporosis fractures are in the pelvis or other bones. And the way that we describe a fracture related to osteoporosis is what we call a low trauma or fragility fracture, meaning a fracture that occurred falling from standing height. In my osteoporosis clinic, I do have a special interest in caring for women who are patients and survivors of breast cancer. So I just want to make the point that osteoporosis is quite common among many cancer survivors. For example, in women with breast or ovarian cancer, there are a number of factors that contribute to bone loss and fracture risk. Chemotherapy can be tough on bones. If there are men listening on this webinar, you are not exempt. And in medicine, we spend quite a bit of time talking about gender disparities, usually referring to how women are underdiagnosed and undertreated for diagnoses and diseases. But in the case of osteoporosis, it's actually the men who are not well diagnosed and treated. So a third of hip fractures occur in men in the US. That's about 75,000 a year. What's particularly striking is that men are actually more likely to die, almost twofold more likely to die after hip fracture. That's perhaps related to the fact that men are older when they have hip fractures, but also men are 50% less likely to receive the appropriate treatment. So for all those men who are listening, do be aware to advocate for yourselves and your bone health. All right, this of course is the lecture for Stanford Care. So Asian Americans are a diverse and beautiful population, the fastest growing racial and ethnic group within the United States. This is data from the Pew Research Center showing a really remarkable climb in numbers. And of course, you know, it's always challenging to discuss Asian Americans in any kind of uniform manner because it's of course a very diverse group of individuals representing many different countries of origin who may have been in the US for a long time, for a very brief time. This again is data from the Pew Research Centers showing the populations within the US and their countries of origin, and you can see again quite diverse. Within the osteoporosis field, we are starting to appreciate the impacts of those diverse countries of origin, but I would say we have a lot of work to do. So this is from an editorial I wrote a few years ago about the importance of understanding the impact of race and ethnicity on fracture risk. And so I want to make a few points. Here is for a given person of the same age, height, and weight, but of varying race and ethnic backgrounds, you can see that the risk for a white woman in the US is higher than that of a woman who is Asian. And these are using fracture risk calculators we have that were developed by the World Health Organization. So in the US, if you're broadly defined as Asian, which of course encompasses many, many different groups, your risk of fracture would be considered lower than that of a white woman who has the same bone mineral density. However, if you look at these are country-specific calculations, again, using the same numbers, but varying the countries of origin. And in red, I've highlighted several countries from Asia. And you can see that there are widely varying fracture rates, starting from a low rate among women in the Philippines to very high rates among women from Taiwan and Uzbekistan. So it raises the question of, you know, what are we actually capturing in this group of US Asians? What if you were an immigrant from the Philippines? That seems like it should be different from somebody who has come from Singapore. Does the length of time that you've been in the country matter? All of these are important but unanswered questions. All right, so now let's talk about who should be tested or screened for osteoporosis and how can we do that? So there are a number of risk factors that are associated with more rapid bone loss. Of course, age is one of them. We are all losing bone as we age. Peak bone mass actually occurs in your late 20s and early 30s. After that, there's a steady decline. Glucocorticoid therapy and other medications, these are including medications that we call steroids. They can be wonderful for reducing inflammation and treating diseases of inflammatory different conditions, but they can cause accelerated bone loss. Family history matters, particularly if you've had a parent who has had a hip fracture. In medicine, we often tell individuals that being overweight is a risk for various health conditions. But in the case of osteoporosis, it's the opposite, that there seems to be an increased fracture risk with low body weight. Other things that raise your risk of fracture include use of tobacco and smoking, excessive alcohol intake, more than 2 drinks a day for women or 3 drinks per day for men, inflammatory diseases like rheumatoid arthritis, and then finally, secondary osteoporosis refers to a large number of conditions, diseases, and medications that can cause bone loss. Why do we need to identify risk factors? Because it turns out that if you look at all the hip fractures, 50% of them happen in only 16% of the population. And these are often, again, patients who've had a prior fracture or who have other risk factors. And the goal here is to try to identify those individuals who are at higher risk so that we can target therapies to increase bone mass and lower the risk of fracture. So the gold standard here in the US for screening for fracture risk is to assess a bone density, and it's done by something called a DEXA scan. So who should have a bone density test? Well, you know, lots of professional organizations have come up with consensus guidelines, and it's generally agreed upon that women who are age 65 and older should have a screening bone density scan. It's generally agreed upon that men should also have screening bone density scans, but the exact age is a little bit debatable. So some societies say age 70, some say 75. Again, men fracture at older age than women. If you're younger than 65, over the age of 50, and have significant risk factors, including the ones that we reviewed on the previous slide, then those individuals might also be good candidates for a bone density test. Anyone who's had a fragility fracture or low trauma fracture after the age of 50. And then finally, if you're taking a medication or diagnosed with other conditions like rheumatoid arthritis that are known to be associated with bone loss, it's important to speak with your doctor about whether you should have a bone density test. So the most common way to assess bone density is something called a DEXA scan. This is our scanner here at Stanford Hospital, along with one of our wonderful radiology technicians. It's a non-invasive, non-painful test. So you simply lie down on this bed. This arm rotates around. So I'd also like to make the point that fracture risk really depends not only on bone mineral density, but also on age. So this is using a calculator called FRAX from the World Health Organization. It allows us to enter an individual's age, gender, weight, height, race, and ethnicity, and calculates the estimated probability over the next 10 years that this individual might experience a hip fracture. And so for various reasons, the professional societies have agreed that when this 10-year risk exceeds 10%, we should think about treating with a medication. I also want to point out that the number of risk factors that an individual has also influences their risk of having a fracture. So again, this is the same woman, age 65, given height and weight, and checking off more and more numbers of risk factors. And you can see that as the number increases, so does the risk of fracture. And this is to make the point that half of all fractures occur in people who have a bone density measurement in osteopenia or higher range. So if you have a bone density scan that comes back with osteopenia, it does not necessarily mean that you're in the clear and not at risk for fractures. So it's important to factor in other things like age and other risk factors to calculate your own personalized risk. All right. Once we've identified that you have a risk of fracture, or you're just wondering how you can be proactive in improving your bone health, there are a number of things that we can all do. So these are the Surgeon General's recommendations for optimizing bone health from a lifestyle perspective. So you can get adequate calcium and vitamin D, and we'll talk about this on the next few slides. Exercise is wonderful for many benefits, including strengthening your bones. You can reduce your risk of falls. So this means things like wearing shoes that are, not likely to trip. Making sure that in your house, if you have, throw rugs, that they're tacked down securely on the floor. Maybe having a night light at night so that when you go to the bathroom, you don't accidentally trip in the dark. It's important to maintain a healthy weight, and again, not too low, because that does raise your risk of fracture. Don't smoke or cut back. If you do, limit alcohol use. And finally, if you're taking medications or you have other conditions that might be associated with bone loss, do speak to your doctor about your risk. All right, so let's talk about how much calcium we need. The goal is generally around 1,000 to 1,200 milligrams per day. You can get this through dietary sources, and the easiest way to remember that is dairy products are a wonderful source of calcium. At the same time as taking calcium, you also need enough vitamin D. Vitamin D is what helps your intestine to absorb the calcium. And so the goal here is roughly in the range of 800 to 1,000 international units a day of vitamin D. So the recommendations are 150 minutes of moderate or 75 minutes of vigorous activity a week. Comes with all sorts of benefits beyond the bones. For bones specifically, it's really helpful to have strength training 2 to 3 times a week. This can be with free weights, it can be with resistance, rubber bands, but something to challenge your strength 2 or 3 times a week. Other things that are helpful are working on balance and flexibility. So if you like yoga or Pilates, the Bone Health and Osteoporosis Foundation has very helpful recommendations here on their website. I also recommend taking a look at this other website, milioguide.com. It's prepared by a physical therapist who really specializes in exercises for osteoporosis. All right, So now we've talked about the things that you can do lifestyle wise to optimize your bone health, but sometimes that's not enough. So sometimes you have either a history of fracture or you have a low bone mineral density on a DEXA scan, and we really need to think about other interventions like medication. This is a busy chart of the different kinds of medications that we have available for osteoporosis. On the top in pink are the anti-resorptives. So these are the ones that stop the breakdown of bone, and again, the most commonly used for osteoporosis. They come in a few forms. There are oral medications called oral bisphosphonates. You might be familiar with them from magazine ads or television. They include alendronate, which is marketed as Fosamax, risedronate, marketed as Actonel. These are safe and effective. The second class of medications is called denosumab. It's a monoclonal antibody against a protein called rank ligand. It's given as a shot in the clinic twice a year, and it has some nice characteristics. It does cause a very significant increase in bone density. It can be used in people who have less than fully functioning kidneys. It's important to remember, however, that if you're on denosumab, marketed as Prolia, that this medication can't be stopped abruptly. It needs to be followed by one of these classes up here. Below in green are the bone building medications, or the anabolic agents. We have three, teriparatide and abaloparatide, which are daily self-injections. And then the most recent medication is called romosozumab or Evenity. This is given in the clinic once a month as an injection. Because these are injectable medications, and because patients often are not enthusiastic about injections, these are not commonly first line, except in individuals who have very severe osteoporosis. And so again, most of the medications are up here. And I do want to make the point that for those individuals who have cancer, most of the safety data has been in these anti-resorptives. So these are the preferred options for individuals who have a history of cancer. The sequence matters. So I mentioned that the anabolic agents are usually reserved for serious osteoporosis or a history of significant fractures. So again, we have three. They must be followed by an anti-resorptive. Otherwise, you'll spend 1 to 2 years of a lot of work giving injections or receiving injections, building up bone density. If you stop and don't switch to an anti-resorptive, all of that bone can disappear quite rapidly. Your options after the anabolic agents are either the bisphosphonates or denosumab. And then again, to make the point that if you're on denosumab, that also cannot be stopped abruptly. So after however many years of treatment, then you would want to switch to the bisphosphonate class. And finally, I want to take a few minutes to discuss something that many patients come to me with concerns about, which is, are osteoporosis medications safe? So in particular with osteoporosis medications, there are very rare side effects that can affect the oral cavity called osteonecrosis of the jaw. This was reported now almost 20 years ago, and in response, there was quite a bit of concern, and many patients and their physicians sort of stopped taking these medications to the point that the numbers of fractures which had been falling over time in the country were starting to rise again. The rare side effects that many people are concerned about are osteonecrosis of the jaw and atypical fracture. And this graph makes the point that they are indeed rare. And in fact, it's a little hard to see, but they're plotted for numbers of years of treatment. So 5 years versus 10. And really, they don't become detectable until patients have been treated for more than 8 to 10 years. And so this has led to the current guidelines, which say that for most individuals at moderate risk of fracture, we can treat for 5 years and then give a drug holiday. And this allows us to very safely use these medications. So again, in the appropriate patients, the benefits of 5 years of treatment for osteoporosis, I hope I've convinced you, really far outweighs the risk. Now, returning to the impact of race and ethnicity, this was a study published a few years ago by Kaiser in Southern California. And it did raise the awareness that, of course, we've known that fracture risk differs between women who are white versus women who are Asian, Black, or Hispanic, all of whom have a lower fracture risk for a given bone mineral density. But this also raised the important point that Asian women in particular may be at slightly higher risk for atypical femur fractures, so one of those rare complications. So it is important to be aware that women of Asian descent do seem to have a different risk benefit profile than other ethnic groups. And so this was just one study, but it was pretty well done with a large number of people. So I have been, in my practice, particularly cautious when I treat women who are Asian, maybe being a little bit more proactive about building drug holidays into their treatment regimen so that we can avoid rare complications. It's also important to point out that these are very rare complications that are time dependent. So again, we really don't see an increase until after 5 to 8 or even 8 years of treatment. And again, now the standard of care would be to think of a holiday well before that time point. The reassuring thing also is that within very quickly after stopping the medication on a drug holiday, that risk seems to fall. So within 1 year off of a medication, that risk is almost back at baseline. And so with that, I want to summarize again take-home messages, which are, I hope I've made some progress in convincing you that fractures due to osteoporosis are indeed a serious public health issue, but often are preventable. That your fracture risk does depend on a number of factors. The most important are age and whether you've had previous uh, fractures and bone density, but other things like your height and weight, family history, other medications, alcohol use, smoking all have an impact. Lifestyle changes are very important. They can definitely slow down the rate of bone loss. They're not often enough to completely reverse somebody who has osteoporosis, but they still remain very important. And when used properly, osteoporosis medications are very safe and effective. And finally, I'd just like to conclude with some thoughts about what we can do as a community to work towards even greater understanding of osteoporosis in Asian Americans. So to start, we need much, much more data, and we need to disaggregate. I won't be the first to say this about Asian Americans, that we really need to disaggregate data by the group of origin, country of origin. We need more information and studies so that we can, of course, maximize the benefit and minimize the risk with treatment and medications. Asian groups in the US include many immigrants, and so the impact of the country of origin and the time spent in the US, I think, are critically important to understand. And then finally, our current calculators don't have any way to assess the impact of risk in individuals who are multiracial. So I think that's another important area that bears studying. We need culturally relevant education. So for instance, many of my Asian patients are not taking in a lot of dairy. So we need to be thinking about other sources of calcium like soy products and other, plant-based milks and other things. And then, as always, we need to work on increasing the diversity of the physician workforce because there's really great evidence that concordance between physicians and patients can help with trust, language barriers, and all sorts of things.